Welcome to Flip Your Script, the podcast from the American College of Lifestyle Medicine that's all about clinicians redefining care through innovation, leadership, and lifestyle medicine. My name is Dr. Padmaja Patel, and I'm the current president of the American College of Lifestyle Medicine and serve as Chief Medical Officer for Nudge Health. Each episode delivers 5 key takeaways from leading experts and practitioners on how lifestyle medicine is reshaping the future of healthcare. Through practical strategies and real-world success stories, we empower you to make a lasting impact in your practice and beyond. In this episode, we are honored to be joined by Dr. Sachin Jain. Dr. Jain is CEO of SCAN Group and SCAN Health Plan, one of the nation's largest nonprofit Medicare Advantage plans, which serves more than 440,000 members across California, Nevada, Arizona, Texas, New Mexico, and Washington. Previously, Dr. Jain was president and CEO of CareMore and Aspire Health, which served 200,000 Medicare and Medicaid patients in 32 states. He also served as chief Medical Information and Innovation Officer at Merck and was Senior Advisor to the Administrator of the Centers for Medicare and Medicaid Services and was the first Deputy Director for Policy and Programs at the Center for Medicare and Medicaid Innovation. Dr. Jain graduated from Harvard, where he earned his MD and MBA degrees. He is an adjunct professor at Stanford University School of Medicine and is a member of the boards of Umada Health, Advantage Healthcare Services, the Paul and Daisy Soros Fellowships for New Americans, and the UCLA Fielding School of Public Health. He's a member of Aspen Health Strategy Group, an initiative of the Health Science, Medicine and Society program of the Aspen Institute, and elected member of the National Academy of Social Insurance. Welcome, Sachin. How are you doing today?
Thank you so much. I'm doing great. It's great to see you. It's been a little while.
I know. So let me pick up right where we left off during our fireside chat at the ACLM conference this past November. And I remember you graciously offered to provide our members with the Medicare Advantage 101 primer. And I want to make sure we dive into that first. So let's start there. Medicare Advantage 101. Specifically, tell us through the lens of lifestyle medicine practitioners, help us understand the underlying business model and incentive structures so we can thoughtfully design programs that create genuine value for health plans like SCAN and others, but also we can deliver meaningful outcomes for our patients. So help us understand this care model.
So first, a declaration of conflicts of interest. I have been working in Medicare Advantage over the last 10 years, so it's a product and system that I believe very strongly in. And so anything I have to say right now acknowledgedly needs to be viewed through that lens. And I'm aware that Medicare Advantage is a controversial topic, but my perspective for the lifestyle medicine crowd is that Medicare Advantage is the best friend that you never knew you actually had. And what I mean by that is it enables you to think about Medicare beneficiaries and people over 65 in particular through the lens of prevention and delaying progression of chronic disease. And that really applies to medical groups that take risk on Medicare beneficiaries. And what that means is rather than actually having the insurance company take risk, if you're a medical group that's taking some form of risk, you are making a bet that your approach to taking care of these patients can actually delay progression of chronic disease and reduce the number of hospitalizations. And if you're able to do that, and you're under risk under the Medicare Advantage program, you're able to make the spread between the expected medical costs, which is for a normalized over 65 population, and the true medical costs. And if you're an entrepreneur who's interested in lifestyle medicine, you really want to familiarize yourself with this concept of being an at-risk medical group, taking risk on this population, and then intensively managing the care of this population. Now, I want to acknowledge Medicare Advantage has gotten a bad reputation over the last couple of years because so much of the focus has not been on medical management. The focus has been on prior authorization, denials, coding, overcoding, stars, and a lot of what I would call regulatory quality as opposed to true quality.
Mm-hmm.
And so I think the lifestyle medicine community has an opportunity to reclaim Medicare Advantage for itself
Mm-hmm.
by actually focusing where the program actually started, which was if we can keep this population of patients healthier longer and deliver lower costs of care, you should be able to benefit and your patients should be able to benefit. That's the win-win that people always imagined around this program. In practice, it hasn't always played out that way. I want to make sure I acknowledge that. But when it's done well and it's done right, that's exactly how it plays out. And that's why I call it lifestyle medicine's best friend that you never knew you actually had.
I love that. So I know SCAN has been a pioneer in value-based care for Medicare Advantage members. As you look at your cost and utilization data, what's the untapped return on investment in lifestyle medicine interventions, such as intensive lifestyle programs? Often we design for chronic disease remission. Do you think are we missing something there, or are we really leaving money on the table for not investing on some of these upstream interventions?
Look, I don't know your community all that well, but I would say that you're in the embryonic stage. I'm still remembering mesoderm, ectoderm, endoderm. If I'm going back to my end, you're somewhere in one of those phases of kind of, I wouldn't call it a phase. Those are different layers. But the point is, you're in an trophoblast or whatever the right phrase is. You're still in the embryonic stage of, marrying the business model with the clinical model.
Yeah.
I think you're super advanced on the clinical model, but on the business model, I think everyone's struggling. And that's where I think, I have some perspective to share. You referenced my history working at SCAN as well as my, prior position at CareMore Health. CareMore was a medical group as well as a health plan. Mm-hmm. And what we saw was really, higher than average, margins in our business because we invested very heavily in a few things. Chronic disease management was at the foundation of everything that we did. And our sickest members didn't just have access to their primary care doctors and their specialists, but they actually had access to what we called CareMore Care Centers, where they had intensive lifestyle management from a chronic disease perspective, diet perspective. They had access to dietitians. And so it was almost like concierge medicine for people with a high burden of chronic disease. And what we saw over and over again was delayed progression to end stage complications. People with diabetes didn't end up having retinopathy and nephropathy and neuropathy at the same rates that patients who didn't participate in these programs did. And we actually did well financially, even though these were expensive programs to administer, because we were fully at risk for the total cost of care. And I would say that these types of models were very popular in the early 2000s and the 2010s. And then as the program, Medicare Advantage program started focusing more and more on risk adjustment and coding, I would say the software got corrupted. And most health systems stopped investing very heavily in, the chronic disease management pieces of this. And they just started focusing on the regulatory quality piece of it, coding and stars. So that's where I think the opportunity exists for the lifestyle medicine community is if you could say, look, we are going to focus on the Medicare Advantage population, and we're going to focus on reducing the overall admissions per thousand, and we're going to delay progression of people with chronic diseases like cardiovascular disease, diabetes, hypertension to later stages. You're going to do better. You're going to do better, in a Medicare Advantage model. In a fee-for-service model, you only get paid when you're delivering services that align with a fee schedule. And, my old mentor in this space, the former CEO of CareMore, a woman named Liba Lesson, used to say, capitation is freedom, not risk. And that's what I want to urge the lifestyle medicine community to actually see is capitation is freedom, not risk. Wow. And see capitation and taking capitation as the opportunity to not be bean counting whether you delivered 20 of a service or 25 of a service, but instead do what you do best, which is focusing on taking care of patients. Now, capitation is one of these words that has really a mixed reputation right now because it was historically used as a vehicle for health plans to pay you less and expect you to do more, and frankly, take financial risk that they didn't necessarily want. I think the combination of risk adjustment plus capitation allows you to actually own the right amount of risk. And again, there's upside downside models, primary care capitation, global capitation. Practices will do what's right for them. But if you immerse yourself in this, I think there's the big unlock that lifestyle medicine has been waiting for. And it's always fun to go to a meeting that you don't normally go to, because you see that there's like these information vacuums where people haven't necessarily been thinking about the things that happen at the other conferences. And so my push to you is for lifestyle medicine as a community to start getting more financially sophisticated. And I think financial sophistication in lifestyle medicine and adjacent spaces has been like, let's just do direct primary care. Let's just get the insurance companies out of it. Let's just focus on, cash pay patients or whatever it is. All the wrong answers from my perspective. I mean, don't get me wrong. You can live in that space and make a good living in that space. But if you're really looking to have impact at the broader population scale for everyone, you need to figure out how to play in these different models. And I would say the additional sophistication, the additional financial sophistication, could move the needle completely for the lifestyle medicine community.
Love that. Yeah, capitation is freedom, and I think that's something we all need to remind ourselves.
Just think about it. If you got the full financial risk or most of the financial risk for taking care of a population, what are the things that you would do? You would do only the things that were really required to keep the patients healthy, yes, and out of acute settings, and nothing more and nothing less. And, particularly in an older adult population, we do a lot of things to people that actually make them sicker, not healthier. We do surgeries on patients who we know are not going to recover well from those surgeries. Those are the kinds of things that should happen as what I call soft utilization management as opposed to hard utilization management. And this is an important distinction that I think gets missed. I think one of the reasons insurance companies engage in heavy-handed, hard-headed tactics is because there is a lot of stuff going on out there that shouldn't be happening. But if the physicians own the risk and the medical groups own the risk instead of the hospitals, then you all would be making the decision not even to offer the procedures to patients that don't actually benefit from them, that they don't actually benefit from, rather. You all would stop giving Q4 or Q3 echoes to patients who don't actually need them. And you know what I'm talking about.
Yes.
You get these reports and you're like, why did this person get this echo? Well, there's no cost to you. There's no cost to the cardiologist. The healthcare system is a blank check for many people, in the fee-for-service world. And that's exactly why we have so much overutilization. And again, I think the way that insurance companies have gone about it, by denying before, it's even rational to deny, is wrong. But I think the opportunity that we have is to flip the script. And if doctors and medical groups could organize to take risk, there's an opportunity to create the kind of financial alignment that has so far been missing in the medical group space.
Yeah, well said. So I want to ask you about pilot programs. And I know you've seen countless pilot programs come and go. When you look at lifestyle medicine interventions, whether it's diabetes remission, cardiac rehab, or even sometimes, culinary medicine, what separates the pilots that scale from the ones that die on the vine? What does SCAN look for? What do you look for when deciding to invest in maybe something like population level lifestyle intervention program?
Yeah, look, I have long said that pilot is a 4-letter word, not a 5-letter word. And the reason for that is that it's oftentimes used as a hedge. It's used as a deferral. It's used as a way for a system to say that they're doing something without actually doing it. And there's too many things that we know are just common sense. Many of them fit into the lifestyle medicine category that never make their way into prime time because of the broken culture of change that exists in most healthcare organizations, which is, frankly, the culture of incrementalism and delayed scaling. And, when you put that up against the amount of turnover that exists in the leadership chain, in the leadership ranks of health systems and healthcare organizations, a pilot is really just a way for many organizations to say no when they don't have the courage to say yes. And it's to say, we're not going to do it at scale, but we'll do it in this small place where it's contained and then we're going to write a press release about it, and then we're going to tell stories about it, and then we're going to go to conferences and talk about how great our fresh food program is, even though 4 people ate meals. That's the broken culture of change in U.S. healthcare. I think so. We try to stay away from pilots, candidly, Padmaja, at Scan. We try to think about, like, let's just do the common sense things that need to be done, that we know work, and focus them on, the populations where we know it's going to have an impact. And so when we introduce, supplemental benefits, we're not introducing it in small scale. We're not doing little micro pilots. We're not doing the small tests of change. We're not doing PDSA cycles. All this verbiage that has found our way into the broken culture of healthcare change and transformation. And we just say we're gonna do it. What that means is we probably do fewer things, but the things we actually commit to, we go hard at and we go long at. A good example of that, is actually our effort, Healthcare in Action, which is a medical group that we launched focused on people experiencing homelessness in Southern California. We didn't do it as a pilot. We started as a new organization. We started small. There's nothing wrong with starting small. But when we proved out a business model and we, built a working approach, we now just do it everywhere that we actually can get paid for it. And so we went from seeing 0 patients to seeing over 5,000 patients, $0 in revenue, to close to greater than $30 million in revenue, focused on taking care of people on the streets of, Southern and Northern California, where we have an epidemic in plain sight of homelessness. And so again, I think pilots are part of the broken culture of change that we have in U.S. healthcare.
Yeah, beautiful. So let's talk about perverse incentives that, a lot of us kind of, especially in the lifestyle medicine clinicians, often find it frustrating. CMS star ratings, which triple weight medication adherence measures. So if a lifestyle medicine clinician successfully uses lifestyle interventions, or say addressing nutrition or physical activity to address blood pressure, cholesterol, instead of prescribing statin or antihypertensive medications, and that clinician could be, dinged or penalized on star ratings. So as a CEO of a health plan and someone who really cares about quality and patient outcomes, how do you address this? And policy-wise, what advice do you have what is it that we should really advocate for?
Well, I think we have to focus on the outcome more than the process. And the example that you gave, we have moved the outcome. And so, the question then I would ask you is, if the hypertensive is no longer hypertensive, then they don't get included in the denominator. So they get pulled out of current measures. If the hypercholesterolemia patient is no longer has high LDL, then they should get pulled out of the denominator. But it really truly has to be the case. And I do think that some people in the lifestyle medicine world, not all, sometimes create these false dichotomies that I think are concerning. It's kind of like the divide between therapy, people who are, psychopharmacology folks and the folks who are more psychoanalytic. The truth is that everything has its place, and everything, needs to be applied in situations and places where it's appropriate. But when we get too heretical about one approach over the other, we oftentimes miss out on opportunities to actually help and serve patients. And so, again, I think the focus should be on the outcome. Like, were we able to cure the patient's hypertension? Were we able to cure the patient's hypercholesterolemia? Were we able to make the pre-diabetic patient no longer diabetic? And if we're able to do that, they should get pulled out of the denominator and not considered in the star ratings. That said, it's really about the outcome. It's not about the measures. And the truth is that we do need to go through a journey of actually shrinking down our measures. I think a next great podcast guest for you would be Dr. Vivek Garg, who's now the CEO of NCQA, a good friend of mine, a longtime colleague. And I know some of what he's thinking about is, how do we actually make measures more meaningful, more valuable to stakeholders across the whole healthcare ecosystem? And I would say it's something that the last generation of healthcare leaders did a bad job of. We had measures creep. We didn't synchronize measures, harmonize measures across programs and across institutions. We got too attached to the things that we were doing. And I think, a role that CMS can play is driving more measure harmonization and synchronization. Now, the dirty little secret is that, measures actually are sources of revenue for
Yes.
for lots of different stakeholders across the healthcare ecosystem. And so there's an inbuilt incentive to have
Mhm.
more and more measures. And so again, I think it's going to require payers, providers, stakeholder groups across the whole ecosystem to start to demand more harmonization and simplification. Because we have too many clinicians chasing process measures instead of actually chasing outcomes for patients.
Yes. So just something recently we all heard, the CMS announced the Medicare Advantage reimbursement rate's going to be pretty flat, right, 2026. And I also saw in the news that SCAN actually enrolled, 40% more members this year. So that's a challenging math problem, more members, but not necessarily, revenue per member. So as you scale rapidly in this zero-sum reimbursement environment, where do you find margins? Does this make the case for lifestyle
It
medicine?
makes the case for lifestyle medicine. I mean, look, I think that maybe CMS overshot, and we're, addressing that with CMS directly. But let's just assume things stay exactly as they are. There's two ways to actually, reduce healthcare costs. One is to lower prices, and the other is to lower utilization. And within lowering utilization, there's, the hard ways to do that, meaning hard which is what health plans do by denying care. And then there's soft which is where I think lifestyle medicine can start to play a role, which is to decrease the amount of healthcare that's consumed because people actually need less because they're
Mhm.
healthier. And
Right.
like that's the long-term fix for this system. If we're going to thrive in a world where resources are more and more constrained and we still want to be humane to patients, the way to do that is to drive their health and to make sure that their A1Cs are lower and make sure that their blood pressures are controlled and make sure that their lipids are under management and make sure that their mental health and their well-being is appropriately tended to. That's a different world, and that's a different world than the US healthcare system is operated with. I think we need lifestyle medicine for all, and I think that you have your moment right now where lifestyle medicine is so closely aligned with some of the very good elements of the Maha movement. There's some, potential risks associated with some of the other messaging that we won't necessarily need to get into. But I will say the good piece is like making America healthy again is like focusing on the true healthfulness of the nation. And the way we do that is by obviating the need for care in the first place. That's where I hope you all take things in the days and months ahead.
Yes. And in closing, I want to ask you any advocacy advice you have, the area where we should be focusing on.
So I think every group like lifestyle medicine is at risk of creating its own language for things. And you can spend a lot of effort creating the language and then trying to be understood by people who don't know your language. And to make it less personal to you all, think about the total quality movement in healthcare that erupted over the late 80s, 90s, 2000s. We started talking about lean events, and we started talking about Toyota Production System, and we started talking about Kaizen, and we started talking about all the different language A4s, the language that we were starting to create around healthcare quality improvement.
Right.
Years ago, I was sitting at dinner with somebody and trying to describe the total quality movement and my own personal fascination with it. And they said, isn't that really just the scientific method applied to quality? And I thought, wow,
Mhm.
yes. And we've created this whole crazy language around trying to improve healthcare quality and reduce costs, and frankly, alienated a lot of the healthcare establishment in the process. My advice to you from an advocacy perspective is to simplify your language. Learn the language of the people you're trying to influence.
Yeah.
Connect the dots for them. Folks in policymaking roles, and I was, fortunate to hold several, earlier in my career, have a lot on their minds and lots of different stakeholders that they're tending to. And so when you force people to learn the language, even lifestyle medicine, what does that even mean? Right?
Mhm.
It's you then start spending a lot of time explaining it. My advice to you is to just align the messaging as much as you can with existing messaging, with
Yes.
existing trends, I think you'll go much farther and much faster if you can actually pull that off.
Well, thank you so much, Sachin. It's always a genuine pleasure to spend time with you. And I'm grateful you joined us today and generously shared your insights and your expertise.
It's my pleasure. And I have, two things to tell you. One is really enjoyed this conversation as well as our conversation at the national meeting recently. And then I recently got a text message from one of our scan physicians, Dr. Balu Gade, saying that he was board certified now in American by the American College of Lifestyle Medicine. So I was thrilled to see that he was board certified, and I was thrilled to see that people that I trust and respect are really seeing the value of the credential and taking steps, even at an advanced stage of their career, to actually gain the credential. I think it says a lot about what you all are doing, and I did want to give a shout out to my friend Dr. Gadi. So
wonderful, thank you. Well, congratulations. I'm glad, and I hope many more of your providers get certified. I think it really would make a big impact in terms of patient care and total cost of care. So what you've highlighted today really underscores the transformative power that emerges out of rigorous evidence, which is already there within the lifestyle medicine, but then there's some of the innovative ideas that you have sort of provided us today. So thank you for your time and your expertise. We really appreciate you. And I want to thank also our audience today for tuning in to this episode of Flip Your Script. We hope today's conversation has inspired you with practical insights on how lifestyle medicine is shaping the future of patient care. If you enjoyed this episode, don't forget to like, subscribe, and leave a comment. Stay connected with us for more episodes featuring clinicians who are rewriting the script on health, one patient at a time. Until next time, take action, make an impact, and keep flipping the script on healthcare. Thank you.
Thanks so much.